Let's start our second session for cardiovascular system. We have take a short break and now we have written the game.
So this topic is about our love for love dub. The love for the love dub. It is about the heart, yes, cardiac and the blood vessels, which is about the vascular component. So it is about the revision of cardiovascular physiology. First we will look into the heart aspects, then we will move into the blood vessel aspect. First, particularly in the heart, potentials are important. Two potential topic, very important image-based question asked many times. First is the SA nodal potential, second is the ventricular action potential. The questions are definitely going to come from here on the name of these phases and also the ions responsible for these phases. Let's see one by one. First, SA nodal potential. This is SA nodal potential. Action potential. The questions are definitely going to come from here on the name of these phases and also the ions responsible for these phases. Let's see one by one. First, SA nodal potential. This is SA nodal potential. Three important phases are here. We have phase 4, which is also called as pre-potential phase. So this is considered to be our phase 4. What are the ion currents responsible? First, a very important calcium ions coming inside calcium influx. It is through a transient type T type calcium current for pre-potential. The second important cause for pre-potential is what is that? IF. The F stands for funny currents. What are these funny currents, sir? They are the special type of sodium ion currents, sodium influx. And third, for pre-potential, there is going to be decrease. Remember this, in potassium moving out. Decrease in potassium efflux. So what are the important causes for pre-potential? A transient calcium coming inside. Funny current sodium ions coming inside. Decrease in potassium efflux. This is pre-potential. Next we have the most important phase 0, that is depolarization. Here it is very unique. In SA node, depolarization is because of calcium ions coming inside. Usually it is sodium everywhere for depolarization, but for SA node it is calcium current, but this calcium current is long-lasting calcium current. So for depolarization, it is calcium influx here, mainly through long-lasting calcium current. And finally, after depolarization, you will have repolarization. This is phase 3, repolarization. Universally, everywhere it is because of potassium moving outside, that's all. So we have pre-potential, T-type calcium, funny current sodium, decrease in potassium efflux. We have depolarization primarily due to L-type calcium influx and repolarization due to potassium efflux. Here we need to discuss the importance of these funny currents. What are they? What is the other name for these funny currents? They are also called HCN channels. Hyperpolarization activated cyclic nucleotide gated channels. What is this cyclic nucleotide? That is cyclic AMP. They are regulated by cyclic AMP here. Next important point. They are responsible for pre-potential phase, we have seen. Usually it is the sodium ion. Such type of funny currents are also present in visual rods and cones. So along with heart, you need to remember, they are also found in rods and cones. Particularly in cardiac physiology, we are discussing. SA node is responsible for generating heart rate. So these funny currents are involved in generating heart rate. So increase in heart rate, arrhythmias. You treat arrhythmias by blocking these funny currents. What is that important drug name? Remember, ivobradine is a funny current sodium channel blocker. An important antiarrhythmic agent useful to reduce heart rate. Ivobradine, funny current channel blocker. Now, I told you SA node is concerned with the heart rate. Now the effect of autonomic nervous system. Obviously, we know, guys. Sympathetic nervous system is going to increase heart rate. How? Parasympathetic nervous system is going to decrease heart rate. What is the mechanism? We will see. I am telling you, this is the effect of sympathetic nervous system. This is the effect of parasympathetic nervous system. That means which important phase they are going to act on? Pre-potential. Which important phase they are going to act on? Pre-potential. Sympathetic nervous system is going to increase the slope of pre-potential. You can clearly see, increase the slope of pre-potential. Parasympathetic nervous system is going to decrease the slope of pre-potential. That's all. Sympathetic nervous system increases heart rate by increasing the slope of pre-potential. Parasympathetic nervous system decreases heart rate by decreasing the slope of pre-potential. Now, from SA node and its potential, let's shift our attention to ventricular action potential, which is even more important, very high yield image-based MCQ. So what are the phases here? We have phase 0, obviously that is depolarization. Here depolarization is because of sodium ions coming inside. It is not calcium. It is like universal phenomenon, sodium ion coming inside, sodium influx. What is phase 1, sir? Obviously it is going to be repolarization. We call this as early repolarization. For all repolarization, potassium ion move out. So the reason here is potassium efflux or early repolarization. A very important phase you exclusively see here. What is this phase 2, sir? Plateau phase. During this plateau phase, remember, potassium ions are still keep on going out, which is balanced by calcium ions coming inside. So for plateau, potassium ions are going out, which is actually balanced by calcium ions that is coming inside. And this calcium current is long-lasting calcium current. So for plateau phase, it is L-type calcium current, very important. Following this, we will have one more repolarization, that is a weight repolarization. For all repolarization, potassium ions move out. So obviously it is potassium efflux. And finally, we will hit this phase 4, that is resting membrane potential. We have to throw all the sodium ions out we have to bring back all the potassium ions, which is actually done by our sodium-potassium pump. That's all. So early depolarization, sodium influx. Early
Sodium
depolarization,
flux,
potassium
potassium
efflux.
efflux.
Plateau phases,
Then
potassium
potassium
moving out is
efflux
balanced by L-type calcium coming inside.
and calcium
Late
influx
repolarization,
again.
potassium moves out,
Potassium
maintaining
influx
resting membrane potential with the help of
and
sodium-potassium pump. This is about
potassium
ventricular action
influx,
potential.
sodium
Now
influx,
guys, the
efflux.
potential changes generated in SA node will be conducted all the way to original ventricles. For that you need a dedicated conducting system. What are the important components, sir? Obviously the starting point is the pacemaker SA node. From there it is connected to AV node. From there it will go to bundle of phase and it will go to all the ventricular myocardial cells with the help of this special type of fibers Purkinje fiber. Now important significance of SA node. SA node is always considered to be the dominant pacemaker. That means there are other pacemakers in heart. It is not only SA node. There are so many pacemakers, but the dominant one is SA node. Why? Because only SA node has got the capability of impulse generation at the highest rate, and that rate is 100 impulses per minute. Impulse generation highest rate, SA node. Then what is the significance of AV node, sir? Remember, exclusively at the AV node, there is AV nodal delay. This is not due to any blocks. This is evolutionary adaptation. This is physiological AV nodal delay. Because whenever atrium is contracting, ventricle have to relax to receive the blood. Atrial contraction, ventricle have to relax to receive the blood. But there needs to be a small delay for this process. AV nodal delay is for that. It is for this reason we always say AV node ensures adequate ventricular filling. We call this as gatekeeper of heart. Dominant
Fastest
pacemaker, SA node. Gatekeeper of heart, AV node. From there the impulse passes to bundle of phase and finally it goes to our Purkinje fiber. What are the important points you need to remember for Purkinje fiber? Exclusively in Purkinje fibers you see numerous gap junction. It is because of this reason the conduction velocity is fastest here, 4 meters per second. Which part of conducting system maximum and fastest conduction velocity Purkinje fibers? 4 meters per second. Obviously, if they ask you where will you see the slowest conduction velocity, wherever there is a delay, where the conduction is delayed, slowest conduction velocity, and the value is 0.04 meter per second in AV node. So fastest 4 meter per second Purkinje fibers, slowest 0.04 meter per second in AV node. This is about the conducting system of heart. Right guys, now we are going to understand the recording of electrical activity of heart. What is that recording? The rhythm of like ECG. How the wave looks like? We have P wave, QRS complex, T wave. At times you also see one more wave, U wave. What is the reason for this waveform, sir? First and foremost, P wave is definitely due to atrial activity, atrial depolarization, duration of 0.10 seconds. QRS complex is ventricular activity, this is ventricular depolarization, similar duration around 0.10 seconds. T wave is ventricular repolarization. So P is atrial depolarization, QRS is ventricular depolarization, T wave is atrial repolarization. Most importantly, they will also ask you what is this E wave, U wave due to? What is this U wave, sir? Remember, it is also repolarization because of papillary muscle repolarization and Purkinje fibers repolarization. So you get U wave at times, which is papillary muscle repolarization, Purkinje fiber repolarization. This is about the basic waveforms. From this basic waveforms, what are we going to understand now? In ECG, whenever you see a straight line, what we call a straight line as segments. Two important segments we are going to understand. Where are those two straight lines? This is one straight line. This is second straight line. So we have PR segment and ST segment. What it denotes, sir? First question they will ask you. PR segment is from the end of P wave to the beginning. Remember, it is the beginning of QRS complex. Correct. End of P wave, beginning of QRS complex. What is this straight line, sir? There is no current flowing here. That means it is my normal AV nodal delay. Excellent. This straight line PR segment is AV nodal delay. Second, ST segment where we commonly look in myocardial infarction. What is this ST segment? We are clearly seeing end of QRS. Correct. End of QRS.
Start of T.
Beginning. Yes, beginning.
End of QRS, start of T wave.
Beginning of this is T wave. So end of QRS, beginning of T wave. In between that we have a straight line ST segment. What it denotes? What is this straight line ST segment? Remember, it corresponds to the plateau phase of ventricular action potential. It also corresponds to our very well known J point, which we look for elevation or depression in myocardial infarction. So PR segment is the AV nodal delay. ST segment is the plateau phase. It is also the J point, which we look for diagnosis of myocardial infarction. This is straight line segment. If you combine a wave and a straight line, it becomes intervals. We are going to see 3 important intervals. What are these? First one is obviously PR interval. Where is the PR interval? This is my PR interval. From the onset of P wave till the onset of QRS complex. See? From the onset of P wave till the beginning of QRS complex. This is my normal, remember, atrioventricular conduction time. This PR interval normally denote the normal atrioventricular conduction time. From the onset of P wave to the beginning of QRS complex. What is second one, sir? QT interval. This is my QT interval. From the onset of QRS complex till the end of TV. Onset of QRS to the end of TV, this QT interval. That times QRS complex and T. That means ventricular depolarization is there. Ventricular repolarization is there. It is my total ventricular act. Comprising both depolarization and repolarization. Clear? PR interval is the normal AV, atrioventricular conduction time. QT interval is total ventricular activity. That important interval between two successive R waves. What is this? The third one. This third one is RR interval, primarily useful to calculate heart rate. How will you calculate heart rate, sir? It equals 1500, 1500 divided by number of small squares between two R waves. Number of small squares between two R waves. 1500 divided by number of small squares between two R waves. This RR interval is for calculating heart rate. So what are the three intervals? PR interval, QT interval and RR interval. So similar to this ECG, one other basic investigation, but helpful so much in lot of diagnosis, that is JVP waveforms. What are these JVP waveforms, sir? You have positive waves. A wave is positive, C wave is positive, V wave is positive. And two important negative waves. This negative wave is called descent. What are these two negative waveforms, sir? X descent and Y descent. What is the basic cause of all of them? It is exclusively talking about the right side of heart, the venous return going to right side of the heart. You always see this JVP waveforms in internal jugular vein. It is in the right side in the internal jugular vein. This A wave is basically because of right atrial contraction, denoting right atrial systole. A wave is a positive wave.
Right atrial contraction makes a corruption को हिमजुद नहीं ना मैं यार.
Right atrial contraction. What is the serious, sir? It is also positive, exclusively seen during right ventricular contraction. Very important. Because of right ventricular contraction, our tricuspid valve is going to bulge into right atrium. This is exclusively seen during right ventricular contraction. Right ventricular contraction, tricuspid valve is bulging into right atrium, you will get CV. X descent is because of right atrial relaxation. This is how you can remember. A wave is right atrial contraction. X descent is right atrial relaxation. What about V wave due to, sir? Right atrium getting filled with the blood. Right atrium gets filled with the blood, you get V wave. Following right atrial filling, right atrium must be empty its content. After filling, it should be empty. For that, tricuspid valve have to open, so that right atrium can empty its content into right ventricle. What we call this concept as right atrial empty. That's all. A wave is due to right atrial contraction. C wave is due to right ventricular contraction. X descent is right atrial relaxation. V wave is right atrial filling. Y wave is right atrial empty. Many times they ask you, what is this X due to? Right atrial relaxation. X is due to right atrial relaxation. So any cause they can ask you. A wave, C wave, X descent, V wave and Y wave. Right guys, from ECG and JVP, where are we now moving on to? Let's cycle for some time. What is that about? Cardiac cycle. Cardiac cycle talks about two important events. One is about the systole and diastole. At times they can ask you a simple calculation based MCQ. They will give you only the heart rate and ask you to calculate cardiac cycle duration. How to find out cardiac cycle duration? Cardiac cycle duration equals 60 divided by the given heart rate. 60 divided by the given heart rate gives cardiac cycle duration. The normal duration of cardiac cycle is 0.8 seconds. Out of which systole is 0.3 seconds. Diastole is longer, 0.5 seconds. The normal duration is 0.8, in which systole shorter, 0.3. Diastole longer, 0.5 seconds. Now, let's understand first the cardiac systole. Remember guys, systole always means ejection. That is the key word, sending blood out. Systole is ejection. The first phase of systole is called isovolemic contraction because during this phase the valves are closed. So valves are closed means blood cannot escape. Volume remains the same since the valves are closed. So we call this as isovolemic contraction. This isovolemic contraction is actually needed to open an important valve. Which important valve will open? At the end of isovolemic contraction, aortic valve opens, so left ventricle can eject the blood into aorta. So aortic valve opens, rapid ejection. After some point of time, the same ejection continues, but slow ejection. So that at the end of systole, we still have some volume of blood left in the systolic volume, which is usually around 50 ml. Systole, 0.3 seconds. Three important phases. Isovolemic contraction, rapid ejection, slow ejection. During systole, aortic valve opens, so blood can be ejected. At the end of systole, we have end systolic volume 50 ml. Now from systole, let's move to diastole. I told you diastole is 0.5 seconds, 5 important phases. What are those phases, sir? The beginning of diastole. Proto means beginning. Protodiastole. During systole, aortic valve opens. During diastole, aortic valve closes. The basic theme in diastole is filling. Systole means ejection, diastole means filling. A similar phase to systole, here it is relaxation. We have isovolemic relaxation. So the first phase is protodiastole. The second phase is isovolemic relaxation. Then the classical filling phases. We have rapid filling, which is followed by slow filling. Remember, together they both contribute to 80% of ventricular filling. It is passive. You don't need the help of atrium for ventricular filling. Rapid filling, slow filling, 80% of filling which is passive. Also remember the last 20%. This last 20% of filling is actually active due to active atrial contraction. So 80% of ventricular filling is passive. Last 20% active due to active atrial contraction. Remember guys, particularly this slow filling phase is also called as diastasis. Okay? Slow filling phase is also called diastasis. So we have protodiastole, isovolemic relaxation, rapid filling is third, slow filling is fourth, filling due to atrial contraction is fifth. So that at the end of all these diastolic phases, we have end diastolic volume. How much is the end diastolic volume? 120 ml. End systolic is 50 ml, end diastolic is 120 ml. Whatever given here in the text form, writing form, let's convert them into a graph. What is that graph called as? Pressure volume graph. So you know everything already. Now it will be very, very simple for you guys. See, this x-axis is volume, y-axis is pressure. Now you help me. What I taught you. What is this 50 ml, friends? End systolic volume. What is 120 ml? End diastolic volume. So between this 50 to 120, ventricular filling happens. 50 is increased to 120, ventricular filling happens. Look very carefully. You have rapid filling, yes. You have slow filling. And the last is due to atrial contraction. Okay? Now, this ventricle is having 120 ml of blood. It must touch its systole. The first phase of systole. This 120 ml volume remains the same, but pressure tremendously rises. What is this phase? Isovolemic contraction. At the end of isovolemic contraction, which valve opens? Aortic valve opens. So during systole, blood is rapidly ejected into aorta. Whatever given here in the text writing form, let's convert them into a graph. What is that graph called as? Pressure volume graph. So you know everything already. Now it will be very, very simple for you guys. See, this x-axis is volume, y-axis is pressure. Now you help me. What I taught you. What is this 50 ml, friends? And this is volume. What is 120 ml? In diastolic volume. So between this 50 to 120, ventricular filling happens. 50 is increased to 120, ventricular filling happens. Look very carefully. You have rapid filling, yes. You have slow filling. And the last is due to atrial contraction. Okay? Now, this ventricle is having 120 ml of blood. It must touch its systole. The first phase of systole. This 120 ml volume remains the same, but pressure tremendously rises. What is this phase? Isovolemic contraction. At the end of isovolemic contraction, which valve opens? Aortic valve opens. So during systole, blood is rapidly ejected into aorta. After some point of time, ejection continues, but only slow ejection. Now, what are the three phases of systole? Isovolemic contraction, rapid ejection, slow ejection. So systole over. Let's begin diastole. Protodiastole begins by closure of aortic valve. Protodiastole. Now, volume remains the same, but pressure tremendously falls. This is isovolemic relaxation. So let's look into the diastole phases. Protodiastole, isovolemic relaxation, right? Rapid filling, slow filling, filling to atrial contraction. So in this graph, at the C point, aortic valve opens. At E point, aortic valve closes. What about mitral valve? Mitral valve is between left atrium and left ventricle. So when mitral valve opens, exactly at the point A, mitral valve opens. Exactly at the point B, mitral valve closes. When mitral valve opens, left ventricle can receive blood from left atrium. So at point A, mitral valve opens. At point B, mitral valve closes. So what is the stroke volume? We can calculate using this graph. Stroke volume equals end diastolic volume minus end systolic volume. That is what is depicted here. So end diastolic volume minus end systolic volume is going to be our stroke volume. So very important thing. We have seen all the phases of cardiac cycle here. That is why I am drawing a line. Anything that is coming above this line is my systolic phases. True. Isovolemic contraction, rapid ejection, slow ejection. Any phase that is falling below this line is diastolic phases. What are they? Protodiastole, isovolemic relaxation, rapid filling, slow filling, filling due to atrial contraction. So from this graph, there are a lot of derivations. What I told you, what is the derivation? Stroke volume. That's what we are going to understand. So what are the derivations? Stroke volume. What is stroke volume? It equals end diastolic volume minus end systolic volume, which equals 120 ml minus 50 ml. How much is the normal stroke volume? 70 ml, simple. Next is ejection fraction. What is the meaning of ejection fraction, sir? Very simple. Ejection fraction equals.
ejection.
We have something called as n diastolic volume.
Diastolic volume.
In this, what fraction is ejected out as stroke volume? Being a fraction, multiply this with 100. That's all. The normal ejection fraction is usually around 55 to 60%. We have n diastolic volume. In that, what fraction is ejected out as stroke volume? So stroke volume by n diastolic volume into 100 is the ejection fraction. How much is the normal ejection fraction? 55 to 60%. But then stroke volume and ejection fraction, what else we can calculate? We can calculate n diastolic volume. N diastolic volume equals n systolic volume divided by 1 minus ejection fraction. Remember this fact. N diastolic volume equals n systolic volume divided by 1 minus ejection fraction. Now it is very simple. How can you calculate n systolic volume? Simple, cross multiplication. N systolic volume equals n diastolic volume into 1 minus ejection fraction. That's all. So from the pressure volume graph, what are the derivations? Stroke volume, ejection fraction, n diastolic volume calculation, n systolic volume calculation. So other way of expressing the same pressure volume relationship is through a diagram that is called Mbbs diagram. I'll show you the diagram. It may look complex, but actually it is very simple because we have discussed the concepts already. See, it is about the pressure and volume. Additionally, you can also see about the electrocardiogram waves and technique of recording odd sounds, phonocardiogram. So along with the pressure and volume changes, we can also include ECG waveform and technique of recording odd sounds. First, look into the pressure. 3 important pressures are shown in this diagram. A huge mountain-like pressure. Mountain-like pressure, blue color, only generated by our ventricular pressure. Very, very small, minute, minuscule pressure changes. Obviously, atrial pressure. And that pressure corresponding between 120 and 80. That is the pressure in my aorta. 120, 80. So what is this pressure, aortic pressure? You can see all the cardiac cycle phases. 3 phases of systole, isovolemic contraction, rapid ejection, slow ejection. All the phases of diastole. Protodiastole, isovolemic relaxation, rapid filling phase, slow filling is also called diastasis, and filling due to atrial contraction. So all the cardiac cycle phases can be seen here. This is in the pressure side. 3 pressures are shown.
Isovolumetric contraction. Ejection, तो pressure over the ejection, isovolumetric contraction over ejection pressure over the isovolumetric reaction over the pressure cut, the rapid inflow जो है बराबर यहाँ પછી मतलब diastasis થાય ને atrial systole થાય અહીંયા કાંઈ ના હોય પછી અહીંયા atrial systole થાય એટલે અહીંયા થોડુંક વધે atrial systole પછી ventricular systole થોડું corresponding જ છે આમ આમ okay. Okay.
Ventricular pressure, atrial pressure, aortic pressure. What about volume, sir? How to check? During systole, because of ejection, volume decreases. During diastole, because of filling, volume increases. During systole, ejection, volume decreases. During diastole, filling, volume increases. The volume is falling, decreasing, corresponds to systole. The volume is rising. We are clearly seeing rise corresponding to diastole. This is about the volume changes. Similarly, we can also see ECG waveform and odd sounds. This is what is very, very important, guys. They will ask you the first odd sound, S1. This first odd sound, S1, is always corresponding to the QRS complex or wave. Correct? Yes. Second odd sound, S2. What is this wave? D wave. End of D wave. Second odd sound. ECG correlation, remember. End of D wave. What about third odd sound, sir? We are clearly seeing the third odd sound. Quickly correlate. That is equally corresponding to the third phase of diastole. What is this third phase? Rapid filling phase. Excellent. This is corresponding to rapid filling phase. S3, third phase of diastole. What about S4, sir? S4 is always due to, remember guys, forceful atrial contraction. Atrial contraction means P wave. So corresponding to this P wave, you can also see a odd sound here, that is S4. So fourth odd sound is due to forceful atrial contraction that corresponds to P wave. So along with the pressure and the volume changes, if you include ECG waveform, if you include phonocardiogram, and also if you include our JVP waveform, ACV, they are JVP waveforms, they are also included in Mbbs diagram. Very important. Question they have asked a lot of time from this Mbbs diagram. Understanding is very easy. So what I told you, 3 pressures are there. Volume decreases during systole, increases during diastole, and hot sound and ECG waveform correlation. Simple. Now, first hot sound is S1. It is definitely due to closure of which all valves? Mitral valve and tricuspid valve. Simple. Second hot sound is S2. So far we have seen first hot sound. Now second hot sound. It is also because of closure of which all important valves? Aortic valve and pulmonary valve. Simple. S2, closure of aortic and pulmonary valves. What is S3? I told you. The third phase of diastole. What is the third phase of diastole, sir? We know it is rapid filling phase. S3. What about S4, sir? S4 is due to forceful atrial contraction. Remember this. S4, forceful atrial contraction. That correlates with the T wave in ECG. So what are the causes for this 4 heart sound? They will ask you. What is the technique of recording this heart sound? That technique is called as phonoaudiography. Phonocardiogram and phonocardiography. Very simple. S1, S2, S3, S4 and their causes. Right guys, from cardiac cycle, let's shift our attention to cardiac output. See, this cardiac output is the product of heart rate times stroke volume. On an average, we consider this cardiac output as 5 liters per minute average. In men and women, it differs. In men, it is 5.6 liters per minute. In women, the normal cardiac output 4.9 liters per minute. This is cardiac output. We have a refined parameter now, a new parameter. What is that? Cardiac index ratio. This cardiac index ratio is expressing cardiac output per meter square of body surface area. So if you relate cardiac output to body surface area, that becomes cardiac index ratio. The normal cardiac index ratio is 3.2 liters per minute per meter square of body surface area. So relating cardiac output to body surface area is cardiac index ratio. How to calculate cardiac?
Cardiac output. Cardiac output is like a heart rate into stroke volume. Normal value 5 liter per minute. On females, 4.9 liter per minute. So, 6 principal on cardiac output is equal to what to consume due to atrial photo difference. Cardiac index. Expression cardiac output per meter square. Cardiac output per meter square of body surface area. Cardiac index. 3.2 liter per minute per meter square of body surface area. Okay.
Output, a very important principle. We call this principle as Fick's principle. Important MCQ. Calculation based MCQ. So cardiac output equals oxygen consumption. They will give you in the question. Arteriovenous oxygen difference. They will give you in the question. So cardiac output equals oxygen consumption divided by arteriovenous oxygen difference. What is this principle? Fick's principle. Now. How can you regulate cardiac output? The mnemonic is CHAP. 3 important parameters. What are all they? C stands for contractility. A stands for afterload. P stands for preload. This preload is directly related to cardiac output. What is the meaning of preload, sir? It is the end diastolic volume. Increase in end diastolic volume always increases cardiac output. We are directly related.
Preload. End diastolic volume. Preload, okay. Load के लिए contraction के लिए होता है end diastolic volume. Yes, preload. तो if end diastolic volume होता है, preload होता है, तो cardiac output होता है. End diastolic volume वही तो obvious है कि cardiac output होता है.
Myocardial contractility is directly related to cardiac output. That means we can increase this myocardial contractility by a very important fraction, and that fraction is ejection fraction. So increase in ejection fraction means increase in cardiac output. So contractility and cardiac output are directly related. The best marker for contractility is ejection fraction. What about afterload, sir? Here is what you have to be careful. Afterload and cardiac output are inversely related. If the afterload is rising, cardiac output will decrease. What is this afterload, sir? It is none other but pressure in aorta or a resistance, total peripheral resistance. If total peripheral resistance increases, if aortic pressure increases, this means afterload is increasing, cardiac output will decrease. So preload cardiac output directly related. Contractility cardiac output directly related. Afterload and cardiac output inversely related. Now, this cardiac output is going to be distributed to all the body regions. Liver ratios, kidney ratios, brain ratios, how much? Next important concept. Organs. First let's look into liver. 1.5 liters or 1500 ml per minute. Second organ. Brain ratios 750 ml per minute. Third organ. Kidney. Kidney is a very small organ but still receives very high flow. 1250 ml per minute. But if you express per 100 gram per minute is very high, 420 ml. That means per 100 gram per minute it is highest for kidney. Overall in ml per minute it is highest for liver. But you express the cardiac output per 100 gram per minute, it is kidney 420 ml per 100 gram per minute, that is highest. Next, what about heart, sir? 250 ml per minute. What about skeletal muscle at rest? 3 ml per 100 gram per minute. So highest cardiac output goes to liver. But if you express per 100 gram per minute, highest is for kidney. So this blood is there mainly needed for oxygen consumption. So next is about oxygen consumption. What about liver, sir? 51 ml of oxygen consumption per minute. Heart is very, very important, guys. Per 100 gram per minute, heart has got the highest oxygen consumption. See, overall, if they ask you oxygen consumption, highest is for liver. But if you express oxygen consumption per 100 gram per minute, it is heart, 10 ml oxygen per 100 gram per minute. Heart is also the region having the highest arteriovenous oxygen difference. Heart, highest oxygen consumption per 100 gram per minute. Heart is having the highest arteriovenous oxygen difference. What about brain, sir? 46 ml per minute. Now, we discussed about the blood flow and the oxygen consumption. For exams, this is what you need to remember. Answer along with me. Blood flow ml per minute is highest
ml per minute is highest for liver.
Blood flow
ml per 100 gram is for kidney. Arteriovenous oxygen difference is highest for heart.
Yes, sir.
O2 consumption is highest for liver.
ml per minute is highest for
O2 consumption
but the same
ml per 100 gram is for heart.
Is highest for heart.
Okay.
Please to revise this, guys, from the entire picture, the essence we are seeing in this slide. One question is sure short. Which organ highest flow? Which organ highest oxygen consumption? Now, heart needs blood flow in the form of a circulation, coronary circulation. All the body organs receive blood during systole, but heart is an exception. It receives mainly blood during the diastole. Which important phase? Isovolemic relaxation. The single most important determinant of coronary blood flow is oxygen demand. The most recent Neet MCQ. It is always the oxygen demand that is going to govern coronary blood flow changes. Primary determinants of myocardial oxygen consumption. What are they? Simple logic. If the myocardial tension is rising, that means the ventricles are working more, there will be increase in oxygen consumption. Heart rate is more, heart is beating more oxygen is needed. Ventricle is working more oxygen is needed. So, the primary determinant of coronary blood flow is always oxygen demand. So, which all is going to rise the demand? Intramyocardial tension, heart rate, ventricular one. Certain chemicals also play a role. Adenosine, potassium accumulation.
Okay. It's been very while. Guys, it is continue. Just 5-minute break. 5 minutes. I will be back in 5 minutes.
consumption of to increase coronary blood flow. So chemicals like adenosine accumulation, potassium accumulation, nitric oxide accumulation can also increase coronary. Blood flow. But the most important coronary blood flow changes. Primary determinants of myocardial oxygen consumption, what are they? Simple logic. If the myocardial tension is rising, that means the ventricles are working more, there will be increase in oxygen consumption. Heart rate is more, heart is beating more oxygen is needed. Ventricle is working more oxygen is needed. So the primary determinant of coronary blood flow is always oxygen demand. So which all is going to rise the demand? Intramyocardial tension, heart rate, ventricular work. Second, chemicals also play a role. Adenosine, potassium accumulation, nitric oxide. They all known to increase coronary blood flow. So chemicals like adenosine accumulation, potassium accumulation, nitric oxide accumulation can also increase coronary blood flow. But the most important is always oxygen consumption, oxygen demand for coronary blood flow. Alright guys, from the cardiac aspect, let's move into the vascular aspect. What is this vascular aspect all about, sir? In the blood vessel, first let's look into blood cells and their development. So we have to look for RBC development, WBC development, and platelet development. What is this process called as? Hematopoiesis. The stages, according to the age of the individual, it varies. From 3 week